Mind affects body, body affects mind. When you can get care for both at the same place, it improves the quality of the care and overall health outcomes.
Most people come to their doctor when they don't feel good.
Once a patient has the insight that they have a problem, and it's usually just they have a symptom that's troubling them, or there's something that's distressing them, going to a doctor's office is comfortable or reasonable, especially if it's a place you've been before for other healthcare problems.
I think that about 70% of all the people who need behavioral health services seek that from their primary care provider.
The barrier, the psychological barrier to going to see your primary care practitioner is a lot lower than going to an entirely new place that you'd never been before.
We've noticed that people turn to their primary care health providers because there's a lot less stigma involved. As soon as somebody says, I think you need to go to the mental health center, there's a gasp of, I'm not crazy.
So I do believe patients will tell their primary care clinicians things that they wouldn't tell a stranger, someone they hadn't met before, someone they have no history with.
We might as well meet patients where they are, which is at the doctor's office.
There's a basic problem with the mental health care system, which we have for a long time blamed on a lack of funding. And I think that what we're finding out as we see the outstanding results of integrated care programs, that money is not the only factor involved here. It's the fundamental structures of the mental health care delivery system that are the main problem.
The statistics are astounding. The U.S. mental health care system, comprised of disparate agencies, community mental health centers, and other providers, serve only half of the mentally ill in the population. Of those, more than 50% are actually served by the primary care system.
So as primary care providers began to make noise about the reality they were facing of becoming mental health providers, writing the most scripts, for example, for depression medication of any provider type in the nation, facing patient resistance to going to specialists, and in many cases facing the reality that patients have no options in their community for mental health services. This idea came about regarding integrating mental health services into the primary care environment. Out of that came the primary care behavioral health model.
By better integrating behavioral health and primary care, we begin to connect the disparate notions that have existed in healthcare for decades. We begin to change the way that healthcare is delivered that's more beneficial for the patient, the family, the community, that can help decrease cost, and that can improve overall patient quality and satisfaction within healthcare.
Well, we now have over 20 years of experience with research and practice with integrated behavioral health care. There are now over 70 research studies that have been done in this area, and if you look at the key message that comes from this body of research, it's really three things. If you have primary care providers, primary care physicians, and mental health professionals collaborate closely, work closely together, caring for a patient, there are three things that come from that. First of all, you get a much better patient care experience. Second of all, you have better health outcomes, and that's not just physical health outcomes, but also mental health outcomes and better functioning in general. And then you also have lower healthcare costs. When you provide this kind of care in an integrated way, it actually leads to a reduction in overall healthcare costs. And today, that is called the triple aim: better patient care experience, better health outcomes, and lower healthcare costs.
As providers of healthcare for communities in inner city as well as rural areas, we recognized very early on that people brought a very broad scope of problems to us. It wasn't just traditional medical, physical health problems. And we recognized that if we wanted to meet their full health needs, that we needed to address their behavioral health needs and quality of life as well. So to meet those needs and help really address improving their quality of life, we had to integrate and change our model of care.
When people access behavioral health care in a traditional medical setting, they can build on the patient-provider relationship that they have already established.
Relationships are the probably primary therapeutic tool that primary care providers have. And behavioral health clinicians who work with them know that and are viewed by the patients as an extension of, oh, this is my doctor's team, or this is my nurse practitioner's healthcare team. They all work together to help take care of me.
It's a completely different way of working than traditional mental health. We work as a team. So we don't have separate offices. We sit side by side in a pod model. The provider will come out from working with a patient, and I'm right there.
We're all physically co-located, so the primary care clinician, his or her support team, which would be a case manager, a referral case manager, a medical assistant. There's usually a nurse who manages the patient flow on the team, and the behavioral health clinician. We're all there, we can all see each other, we can all see what patients are in rooms and which patients are waiting and who they're waiting for.
For example, a patient with a new diagnosis of diabetes. The therapist can go in and speak with those patients directly right after I come out of the room and say, it sounds like your depression is worse. I would really like you to see a therapist. Great. Would 2 seconds from now be okay? Let me go talk to my behavioral health professional.
Mostly the medical provider, the primary care provider, has the primary relationship with their patient. So doing that warm handoff and actually introducing me so that the patient sees the medical provider and me, like they get that image that we are on the same team, we're working together, and it helps start to build that relationship of trust.
When we think about our typical primary care patient and the comorbidities and co-occurring disorders that they have, I think as professionals we had to ask ourselves, are we really going to ask our patient to go to 3 different providers, 3 different times in 3 different locations? And do we really think that we should inconvenience our patients who are already so challenged and fragile to navigate the system like this? No, I think we need to change. We need to start believing in integration, and that primary care providers need to understand mental health and substance abuse need to talk to each other or become one. And we also have seen North Baltimore Center's patients in Baltimore for many years. Through their care managers, they would walk them over and we would see them for their primary care needs. So I think we sensed that there was a very fragile, medically fragile population out there that wasn't being served at an extent that they should be served. So I think that's what inspired us to embark on this collaboration.
For the behavioral health side, I think one of the pushes was in the recent past when the feds came out with the outcomes that the mentally ill population is dying 25 years earlier than you or I or the norm population. So it was a push to really focus on total health and our patients' overall total health.
Cherokee Mental Health Center was the original name of the organization, and we began as a mental health center. We found in working with patients that some of our areas were really short on primary care, and we also realized that in primary care there's a lot of behavioral health. So in order to improve overall care in our community, we branched into primary care in 1984.
I think you're definitely a team player, people who are good communicators, people who are high energy, because primary care is high energy and fast paced, and flexible, because I interrupt Amanda multiple times, she'll interrupt me, and that's a good thing, to be able to be flexible, because I'd rather handle something right then and there than wait until later.
Well, I think that you can be more comprehensive. You have resources around you, and you're more likely, with a physician that has immediate access to someone, you're more likely to go into more depth and investigate that and to come up with a treatment plan on the same day instead of leaving an unanswered question, you know, to try to think of it after a busy day, you know, what have I not addressed today? So I think having the resources around you, having the team in place that can work with these issues together on the spot and not having to bring the patients back 2 weeks from now, 3 weeks from now.
We found that the best model is really nesting a behaviorist in the primary care team. So we have embedded behaviorists in the primary care team. These behaviorists function with a schedule that's very much like a primary care provider. It really mimics that pace. They are available real time to deal with problems that come up in the primary care environment.
I'm Sandy Becker, and I work at the Trenton Medical Center, a primary care group.
I'm Rose West. I work at Meridian Behavioral Health Care, so we provide the behavioral services, mental health, and substance abuse. I think probably on both ends we see the same clients, and whether it's our clients, you know, on the primary care side that have, you know, chronic conditions, chronic medical conditions that they're not getting met, and that's sort of affecting their care on our end. So they're not able to focus on getting the treatment for their mental health or substance use needs, or on the primary care end, you know, them not being able to follow whatever recommendations are being made by the physicians because their mental health conditions or their substance use conditions are, you know, affecting that, sort of serves as a huge wake up for us that we need to be doing something so that, you know, our clients are getting the care that they need to be able to manage their conditions on both ends.
In our community alone, I mean, I'm sure others, it's a strong need, you know, great need to have our patients treated not only physically but mentally. It just seems to go hand in hand. When you work on part of it, they're not treating the whole body. And we just felt like, you know, we definitely needed to have some mental health, behavioral health in our community also.
Well, it's really quite phenomenal, the growth in behavioral health that Lone Star Circle of Care has seen in just the past few years. In 2006, we had one psychiatrist in the Georgetown Family Medicine Clinic, and now we have 13 psychiatrists and nearly, I think, about 25 psychotherapists. When one is providing medical care to the patient who is really the center of Lone Star, our mission patient, underserved, uninsured, underprovided for, that sort of person has usually had a lot of difficulty in their life, just trying to make it day to day, supporting themselves, supporting their family. The stresses of living in poverty, of living without, are tremendous. And so you see problems with depression, anxiety, substance disorders, which then spiral into bigger and worse things.
Now is a great time to integrate primary care and behavioral health, not just in terms of policy, but probably more importantly in terms of the impact policy has on the actual care that patients receive. We're seeing collaborative care unfold at an unprecedented pace all across the country. Every geographic region that you can think of is doing something to integrate primary care and behavioral health. From the Northwest region all the way to the other side of the country in Florida, I've been amazed at the progress in just such a short amount of time. And this is a direct result of both policies as well as personal feet on the ground incentives to do the right thing for patients.